Do you find that the data coming out at San Antonio Breast Conference is different than some of the other major conferences?
Yeah, it's very breast specific. That's why. I mean, you've got, 10, 15,000 people that do nothing but breast cancer. Whereas at
Right,
ASCO, it's 40,000 people, and breast
right,
cancer is part of it. Obviously, breast cancer is a third of all cancers.
right,
But, breast cancer has its spot among everything else. San
right.
Antonio is specifically breast cancer. I think the big meetings used to be San Antonio and ASCO for breast.
Mhm.
Now we have San Antonio, ESMO, and to a lesser extent, ESMO breast. ESMO Breast is just so close to ASCO that a lot of people just want to. ESMO Breast is usually in May. And so it's so close to ASCO that people usually reserve the big abstracts for
Mhm.
ASCO, the big practice changing ones, although ESMO Breast occasionally has them. But it really, stuff that people don't want to wait for San Antonio in December, they'll
Mhm.
put it as a late breaker to ESMO over the summer. So we're seeing a lot more stuff come out, like Keynote 522, where we use
Right,
immunotherapy for breast cancer, came out at ESMO.
right.
Some of the ADC trials. I think not Destiny 04, but I think Destiny 03, which was the big one, second line HER2 positive, came
Mhm.
out at ESMO. So, we have three trials, three meetings where, you can put stuff in. We really don't have a good spring one, a real spring one. Like ACR is okay, but that still is a lot more translationally based.
Mhm.
And again, if ESMO Breast was like a month or two earlier, I think maybe people would want to submit more of the practice changers to that.
Right,
But that's kind of how things are going now.
right. That makes a lot of sense. And so for your paradigm of metastatic breast cancer, are you sending germline and somatic testing at the outset for everybody?
Yes, I think that's the point. We want to in metastatic disease, definitely. It's just a question of when you do it. I think the other big kind of movement in breast cancer, it probably will never happen to the extent we want it to, is the recommendation of ASCO as well as the SSO, is to do germline genomic breast cancer testing on everybody with breast cancer. So under the age of 70. And the rationale for that really is the fact, and again, the update was presented at San Antonio this year, is there's a clear overall survival benefit to the adjuvant use of PARP inhibitors in people who are very BRCA mutated.
Right.
And so I really think that's important. It won't
Mhm.
happen in the vast majority of people. So when people do get metastatic disease, we know 5 to 10% of the ER positive patients and about 15 or so percent, if a little bit more, of the triple negative patients have
Mhm.
germline BRCA mutations. And a certain percentage can have somatic BRCA mutations that come out on next gen sequencing of the blood. So, or tumor. So, we definitely need a germline BRCA testing in metastatic disease, so everybody will get it at some point. And because of ESR1 mutations and PI3 kinase mutations, we
Mhm.
need somatic germline testing,
Right.
somatic NGS
Somatic.
testing.
Yeah.
And the question is when.
Right.
I think now that we have a triplet that involves a PI3 kinase inhibitor, we have
Right.
inavolisib, palbociclib, and
Right.
fulvestrant in high-risk disease. I think that there'll be a lot more germline testing somatic testing in the first line. A lot more somatic
Mhm.
NGS now off the tumor. Most of us have done somatic NGS off the blood at progression on CDK4/6 inhibitors because we really had
Right.
nothing else. We knew CDK4/6 inhibitors work really well.
Right.
But now we have something, the triplet. So that's going to really drive a lot of PI3 kinase testing earlier
Right.
than we normally would do.
Well, that's exciting. It's like the era of precision oncology in all tumors is moving into an earlier setting. So
It
hopefully,
really
of
is. And I think, again, at the end of the day, we would hope this shows a survival advantage to doing this.
course,
That's always the end of the day is
question.
we want people
Right.
to live better and live longer.
Right.
And not just simply just go on PFS by radiological progression.
Yes.
And I think that as long as we can show this, and I think we are, showing that early introduction of these targeted agents really does improve people's quality of life, number one, because they don't have oral chemo, IV chemo, and number two, because it does improve their survival. I think it's starting to show us that the benefit of doing this.